My patient story. Prior to my illness, I worked as a clinical nurse manager on a busy medical ward in an acute hospital. I'd been feeling unwell for several months, but I put it down to a busy lifestyle. Reluctantly, I attended the medical assessment unit while at work one day, when a very close colleague insisted that my breathlessness was not due to being unfit, as I had tried to reassure myself. My diagnosis came as a shock, or rather disbelief. I was referred to a specialist surgeon and still believed that technology was not giving an accurate diagnosis. I was now labelled an unwell patient, and for me this was a life-changing event. My ultimate goal was to get better, protect my loved ones. Unable to have surgery performed in my local acute hospital, I was referred to another site for pre-operative assessment. I can still remember my reaction when asked what my understanding of my diagnosis was. I mumbled a few words out, and as the surgeon sat and spoke to my husband and explained the procedure for the first time, I felt panicked. I, the nurse, was no longer in control, or did I clearly understand the severity of my diagnosis? I often reflect on that meeting. I had worked as a nurse in acute medicine most of my career, but yet in that moment I felt I had lost all my knowledge base. A date was scheduled for surgery. However, there were the usual delays, awaiting swab results and a bed, and while this time was invaluable with my family, it was frustrating waiting for calls and communication, and this really embedded the distress. I wanted to have my procedure and have a better outcome. I could now empathise with patients and their families awaiting admission. They're planning on the pretense of getting a bed and a certain date at a certain time, arranging transport, childcare, pets, loss of earnings. When our new admissions arrive to the ward, do we pause and think about the patient's journey to this point, what they've left behind at home, their personal worries, fear for their loved ones, questioning silently in their own minds will they return home? The HSE Incident Management Framework 2020 defines just culture as one which refers to a values-based supportive model of shared accountability. It states that individual staff should not be held accountable for systems failures over which they've no control. Instead, organisations need to encourage staff to report such incidents and near misses and apply systems learning to improve patient safety. On reflection of my 3-month stay in hospital as a patient, I recall events where I became very aware of the need to always support colleagues. I recall the day my chest drain was removed. It was coming up to staff break time. A new nurse was being supported by a senior staff nurse to carry out the procedure, her first time. There was a rushed conversation at the bedside. The staff nurse supervising the other staff member removing the chest drain was impatient, insistent on getting on with it, and had an urgent attitude. Beads of sweat ran down the face of the nurse removing the drain as I lay afraid to move. I often regretted not intervening and speaking up to support the nurse removing the drain. But was this my role as a patient? The subtle nature of interpersonal fear at work crept in. I want to focus on 3 key patient safety themes and share these themes that resonate so strongly with me. The first theme, deteriorating patient. Memories come flooding back. The relief of having a trolley to lie on when there were no beds available. The relief when staff identify a room to wheel that trolley into, to allow some level of dignity and respect for assessment and examination. Your story doesn't need to be everyone else's business. My own personal emotions while unwell. The greatest was fear I had never felt so strongly before in the hospital. This technically was my second home, and my colleagues were my second family for the last 22 years. We speak about emotional intelligence. Remembering one Friday afternoon being extremely breathless and tearful on my own in the room, the cleaner coming into the room and seeing that I was upset, acknowledging it, and offering reassurance and help. My admission to ICU as a deteriorating patient. We speak about psychological safety. I recall my colleagues contacting the night sister to inform her of my early warning score, a tool used in acute hospital settings to support the recognition and response to a deteriorating patient. The battle between the night sister on the corridor, insisting on my transfer with the anaesthetist to transfer my care to ICU. The anaesthetist had assessed me. I was alert, orientated, and honestly hated to say that I felt so bad. Was it fear of being labelled? My early warning score was increasing, parameters changing. The key intervention the next morning of a nursing colleague storming out of the room when she saw me, ringing the treating consultant and insisting I was seen urgently, and within an hour I was in ICU. I felt such empathy for my former work colleagues, as particular nurses accompanied me to the ICU. These were my colleagues and friends who I knew would go to any lengths for what they believed would assist or comfort any patient to recover or aid their distress. My time in ICU gave me a clear understanding of the vulnerabilities of patients as unique individuals. My second theme relates to communication with patients and family. As mentioned earlier, my first consultation with the surgeons, my husband felt involved and supported. He always recalls the morning of my surgery, arriving on the ward at 8:30 a.m. We didn't expect to go to theatre until about 10. A young staff nurse appeared at the door, chart in hand, accompanied by the porter to escort me to theatre. Both myself and my husband became emotional. She told us to take a few minutes and left the room. Her kindness and empathy will always be remembered. From the start, we had decided to be open and honest with our children, then aged 16, 14 and 10. My prolonged hospital stay impacted their lives. While I spoke on the phone individually to my children and listened to what was happening in their lives on a daily occasion, I could sense their fear when they questioned my care and why I wasn't getting better quicker. As a patient, I now realise this communication, planning and support means so much. I was fit, strong and young, not frail, vulnerable or elderly. I was in pain on occasion and breathless. I was not afraid to ask questions nor to speak up for myself. I knew I was in good hands. Not all patients have this luxury. I felt supported on the ward when all disciplines carried out their role. However, I also felt the frustrations of my husband. I had so many disciplines looking after my care, all searching for answers, now 9 weeks in hospital, but could not get to the root of the problem. I recall him saying to me one evening, "Thank God you're a staff member, otherwise I think you may have died." My husband was always respectful that the team would speak to me directly as a patient. However, I wondered, if I wasn't a nurse, would he have felt the need to be more vocal or advocate for my care? As a nurse, I understood things were not always clear-cut, and thankfully healthcare has taken the proactive, multidisciplinary team approach, meeting and discussing complex cases. While I know there were plenty of corridor conversations amongst clinicians, but I was never aware of an MDT approach or any review. As a patient, we want to concentrate on getting well and haven't got the energy to sometimes question the bigger picture of our care. Team 3, the long-term effect on my identity and work. After 18 months and several occupational health appointments, I was able to return to work. For a while, I thought this might not be an option. I missed my team and colleagues with whom I had shared life events, and also missed my patients. Occupational health felt it was not appropriate for me to return to a clinical setting. Starting into a new, unfamiliar role, which was out of my comfort zone, was daunting. I missed my team and the comfort of the familiar, and the routine of a job in which I was very skilled and experienced. I felt I was no longer the very capable nurse. My new role often found me in a very reactive space where patients had a poor experience or outcome. My experience as a patient has enabled a deeper understanding of the difficulties and challenges for patients. The dread of waiting for care and treatment, frustrations while an inpatient to have procedures scheduled, the importance of communication between patients and healthcare staff, the importance of openness, transparency and building trust, always being honest even when we don't have the news they're hoping to hear. The emotional turmoil for families journeying with their loved one. I'm so aware of what a kind word or smile can mean to a family member, and I'm also aware of the look on a patient or family member's face that says, "Can this day get any worse?" I can recognise the time in my career when I didn't feel competent to express my concerns regarding a patient. I'm very aware of the challenges for staff, language barriers, cultural awareness, competency, and in recent years, burnout. Yet I still believe it's a lot easier to be a nurse than a patient. My own personal journey as a patient gave me a new concept of quality and safety of patient care.